American standard in this to get this to happen. And I don't by any means fit into the scale and scope of what you describe, but when you had asked people to maybe bring 1 or 2 cases, I figured this would be the bumper on the end of a big experience and not the start. So with that end, it's just a couple of things that I thought might be a little bit different. Could you bring the lights down just a little bit? It's probably a little bit easier. I'm not sure I turned up the contrast that much. And this was basically just to point out some observations for those who are starting to look at this, which is, I think that you can induce a lot of narrowings based on how you position people. And that's just an example of what rotation does. And if you look toward the ipsilateral side, you can actually narrow it by muscle. And unless we decide that you're going to hold your head in that position chronically, then that may just be a physiologic thing that we shouldn't be treating, and that's got to be distinguished. I think venography, as some of us were talking about at lunch, is still a bit of a black art in terms of consistency, and one of the things that we need to do is to be able to think about more reliable and uniform protocols and how to do this. And to that end, at least for me, I found that intravascular ultrasound is very useful. I'm sorry I couldn't bring you pictures from that. And to emphasize the point, I put this in because Dr. Sclafani had showed a picture of an azygous vein to show you that a picture like this, at least for me, doesn't necessarily clear the azygous vein because there are subtle valves inside of it as well. This one happens to flow rapidly, but I've cleared it with intravascular ultrasound. And I think that it's easy to over and to undertreat things based on how much you inject or under-inject, or whether you're filming it fast enough. And in fact, the way I approach these is not the same vigor of injection as the protocol that you showed. This is the other side of that patient, and this is actually a fixed stenosis, which is not due to rotation. Yes, we have collaterals. I'm injecting at a very, very gentle rate below and also above, almost not at all, so as not to over-magnify the effect of these things. And this is external compression, and I have that from the IVUS as well. And that's even in neutral and all forms of rotation. And that's not, I would think, arguably something that is going to improve with balloon angioplasty alone. So we've got to get our heads around the fact that there are many, many different mechanisms, as you said, that may need to be addressed as we start to suss this out. That's another close-up, very low volume injection of the same sort of thing from just below. It's not spasm. There's not any question of that. We've confirmed it with intravascular ultrasound. That's different than the smooth narrowing on the other side. And these are some of the things that I think we're all learning about these types of things. And this is the result, if you see through my numbers, of a response to an angioplasty. Pretty trivial, still a hang-up in contrast, and that's after treatment as well. So I think that there isn't sort of a one-size-fits-all approach to treating these types of things. We still are asking how much has to be treated in individual patients. And you can get remarkable stories almost immediately that amplify the types of things that we heard other speakers beforehand. I don't think that we necessarily need to read this except to say that I think in that patient that was really the one underlying thing. And if we had left it with angioplasty, then we may have undertreated. And I think we have to decide, do we want to be on the completely conservative end and be wholly and maximally safety-driven, which is smart. Somebody's drowning, you can throw them something to save them, but it can't be a brick. And the other end is extreme, and one thing we have to do in doing this is have uniformity and not whipsaw back and forth in these procedures, otherwise we'll never... This is an MR. I'm sorry I couldn't bring you the coronal, which would be easier to look at. But you saw some of these earlier with Dr. Hackey. You see a very large jugular vein on the left, and we'll swing over to the right. And this, I think, is a collateral. I don't think it's a duplication. I think it's an anterior jugular. I watched it up with the ultrasound, and we could see that it's at dorsal to the jugular vein, and that the original jugular vein was small and narrowed at its base. So that's actually an example of finding, to emphasize again what you had said, Sal, about other veins and having to find the correct one. That's the collateral, that's the wrong vein. This is the right vein. And that's the right vein, and you can see that, and that late image of contrast is simply sitting there, stagnant at that point, because the narrowing is only as large as the tube that we put through it. This is contrast that was simply sitting stagnant. So you'd say, why, when the opposite jugular vein is so very large and either born that way or presumably had enlarged over time, would opening this relatively smaller underlying vein make a difference? And the answer is, it did. I'm sorry that I can't quite play. This is with patient's permission. We don't quite have a sound, but essentially what she strode in as if she had had that cup of coffee that I need every morning and without her cane. And I was just sort of stunned. In fact, that's why we shot this sort of impromptu cell phone video. But then, you know, this was treated with angioplasty, but I don't know that that shouldn't be stented either. These are the types of things that I think are the ones that we're working our way through. And as we think, as someone who is interested in the quality of scientific literature, we have to remember that this is sort of the way that we want to advance, which is from reports and expert opinion to case studies I did in 1 or 2 or 3 to patients prospectively and retrospectively, and ultimately to randomized controlled trials, the pinnacle of the literature. But almost everything in interventional radiology has largely lived in this space, and we have done good and wonderful and important defining things for patients in that, in cancer and fibroids and peripheral arterial disease. So there is a lot of room for developing this very type of literature rather than necessarily saying that the only things that we can really do, in my opinion, are randomized controlled trials. And these are really sort of the things that we have to figure out, which is where is the reality and how do we decide, and what is the physiology, how do we choose, do we have rulers that are uniform, what do we know about durability, we've got to validate screening efficacies as well, we can't have the MR trump the venogram, and vice versa. There isn't necessarily a clear gold standard, and ultimately we're going to need things that are standards so that when we have registries, the data is actually going to be uniform and useful, and that's the old saying, GI Joe, garbage in, garbage out. So these are good times for a lot of good, measured, and rigorous patient follow-up and uniformity of procedure as well. That's all I brought, Scott.